Alright, welcome back. So we're just going to talk about ECGs real quick. I'm going to play a video first, and then we'll get on with some more stuff. Where did I put that video? Here it is. Okay.
The heart's conduction system controls the generation and propagation of electrical signals, or action potentials, that cause the heart's muscles to contract and the heart to pump blood. This electrical activity can be measured at electrodes placed at specific points on the skin, from which a composite recording is produced in the form of a graph. This recording is known as an electrocardiogram, or ECG, sometimes referred to as an EKG, a tracing of the overall electrical activity of the heart, resulting from the propagation of many action potentials. Let's look at what happens during a single beat of the heart and how these events are depicted on an ECG. In a normal heart, each beat begins in the right atrium with an action potential signal from the sinoatrial or SA node, the heart's natural pacemaker. The signal spreads across both atria, causing the muscle cells to depolarize and contract, inducing a phase known as atrial systole. On the ECG, this atrial depolarization is represented by the P wave. The period of conduction that follows atrial systole and precedes the contraction of the ventricles is depicted on the ECG by the PR segment, a flat line following the P wave. When the signal leaves the atria, it enters the ventricles via the atrioventricular or AV node, located in the interatrial septum. It enters the bundle of His and spreads through the bundle branches and the large diameter Purkinje fibers along the ventricle walls. As the signal spreads through the ventricles, the contractile fibers depolarize and contract very rapidly, inducing ventricular systole. The ECG's QRS complex represents this rapid ventricular depolarization. Atrial repolarization also occurs at this time, but any atrial activity is hidden on the ECG by the QRS complex. Finally, as the signal passes out of the ventricles, the ventricular walls start to relax and recover, a state described as ventricular diastole. The dome-shaped T wave on the ECG marks this ventricular repolarization. On the ECG, the ST segment depicts the period when the ventricles are depolarized. The QT interval represents the time it takes for both depolarization and repolarization of ventricles to occur. The sequence of events just described and the associated ECG trace repeats with every heartbeat. Remember, an ECG is not a tracing of a single action potential, but an amalgamation of the many action potentials that constitute the electrical activity of the heart.
You like that amalgamation? It's a pretty good word, huh? Alright, let's go back to the slide because I want to talk through this with you. Okay, so this atrial depolarization business right here. So from the previous video, you remember me saying that depolarization is that charge, that like pushing out, that real, usage of the electrical impulse that we got stored up during polarization, right? So atrial depolarization, it presents itself as a P wave, okay? This tiny little hump that happens before this big mountain peak. So in this tiny hump, this is where we see that the atria are filling with blood and passively pushing it back through the valves into the ventricles. Okay, so that's where the atria are depolarized. They are told, hey, receive the blood, but then passively fold it down and push it into those ventricles. So what you're seeing in this P hump here is that folding of the atria, pushing it down into the ventricles. Okay, so after that happens, there's a little period of rest right here in this interval. Okay, this little flat line. So after that happens, the ventricles then need to depolarize because they've filled with the blood. that electrical impulse has spread to those ventricles. They need to get rid of that blood. They have got to push it out. Okay, so what we see there, and remember when we were looking at the picture of the ventricles, they have a lot thicker and more of the myocardium surrounding the ventricles, so they have a lot more ability to push and force through that blood. So that's what we're seeing in this mountain peak here. We're calling it ventricular depolarization, but it's also what during ventricular systole. Okay, so ventricular depolarization and ventricular systole are happening at the same time, which means the ventricular depolarization is talking about the electrical impulse, and systole is talking about the actual action of the ventricle pushing out the blood into the next area, wherever it goes, whether it's right or left. Okay, from the right, it goes into the pulmonary arteries, into the lung. From the left, it goes through the aorta and out to the body. So that's what's happening right here in this mountain peak. Okay, so after that happens, the heart is exhausted. It has done so much work from the atria filling and folding and pushing the blood through to the ventricles, receiving that blood and then pumping it out and needing to just drop after a minute. And there's this little period of rest. Okay, and we see with the T wave here, your ventricles are repolarizing, which means they're recharging. They're getting ready to do it all over again. Every now and then you'll notice a U wave. Sometimes it just blends in with the T wave. A lot of times you don't see a pronounced U. You just see the T, okay? The QT interval, like we said, is just everything happening with the ventricles, and this PR interval is everything happening with the atria, okay? I know this is fast and furious and a lot of information and something that you're just not at all familiar with yet. That's okay. Watch and rewatch my video and this other video. Ask questions. Let's talk about it in class, and you will get comfortable with it. Okay, so let's move on to the next thing. So these are terms that you've learned in the past, I'm pretty sure of. The cardiac output is just talking about the amount of blood that's pumped out of that left ventricle every minute. Okay, and an average healthy adult, it's 4 to 8 liters per minute. It's a lot of blood, okay, every single minute, 4 to 8 liters. All right, just think about, those water bottles that you drink, you buy them at Walmart or whatever, those are only half a liter. So that means that there's 8 to 16 of those things being pumped out of your left ventricle every single minute. That's mind-blowing in my opinion. Stroke volume is the amount of blood that's pumped out every contraction, okay? So every time you have ventricular systole, blood gets pumped out. Every beat, every contraction, okay, that is stroke volume. In a healthy adult, it's usually 65 to 70 milliliters per contraction, which is still quite a bit considering we have 60 to 100 beats per minute, right? It's a lot of blood getting pumped through those hearts. Isn't that cool? So the formula to figure out your cardiac output is if you know the patient's heart rate and you know their stroke volume, you just multiply them together and there's your cardiac output. It's easy enough, right? Because cardiac output is measuring minute. Our heart rate measures per minute. Stroke volume is just per contraction, so per beat, right? Multiply them together, cardiac output. So whenever you are caring for a patient who has any kind of cardiac difficulty, or if you're trying to determine if they have cardiac difficulty, we need to do a general assessment, okay? And we're really paying close attention to certain things whenever we're trying to diagnose a cardiac issue. So, initially, we really want to look at their behavior, their posture. Are they anxious? Are they depressed? Do they have pain in their chest or their legs or their arms? All of those could signal ischemia, which just means a lack of oxygenated blood flow to that area. Okay, so if they have chest pain, that means there's a lack of oxygenated blood flow to their heart, probably, right? If they have pain in their arm, that means there's lack of oxygenated blood flow to their arm, which could signal to you that they probably have a clot or some other kind of issue with their vessels that is not allowing for them to have the oxygenated blood flow to their arm. Legs, same thing. So it's very important to note those different areas of pain. Their temperature. Is the inflammatory response initiated as a result to maybe myocardial cells being damaged, or after a myocardial infarction, or after an infection or something? Is their pulse weak or thready, or is it really bounding and irregular? We need to know these things because they could signal different disorders and diseases. We'll get into what these things signal later on, more specifically with the infections that we will talk about. But it's really important, again, to look at this. So are their respirations labored, shallow, or noisy? Could be, maybe that the blood flow is compromised and is backing up into their lungs. Who knows? But we really need to check that out. Is their blood pressure changing? Is it elevated or low? Does it change with orthostatics when they stand or lie down or sit? Are they dizzy whenever they stand up or change positions? That could signal to you that they might be hypotensive or, just have really poor circulation. What do their heart sounds sound like? Or do you hear the S1 and S2 that are regular and steady? Or do you hear an extra sound in there, an S3, or anything else that could be happening? When we listen, we hear lub dub versus lub dub D or lub dub dub. Okay, and we'll listen to different sounds when we're talking about the valve issues and everything too down the road. Okay, what does their skin look like? Are they pale, cyanotic, diaphoretic? Do they have varicose veins? That could signal poor perfusion. Are they edematous? Okay, because if they have swelling anywhere, then that could signal to us that they have inefficient pumping in their heart. Their fluid is all backing up because the vessels are not carrying the blood backwards and forwards the way it's supposed to be carrying it. It all backs up and the fluid, seeps out into your extremities and you have that swelling. Not good. Are they having weight gain? Okay, sometimes we don't notice really if it's edema or if it's weight gain for other reasons. And so sometimes marked weight gain, typically, like if it's more than what you would expect somebody to gain, like 10 or 15 pounds in the last week or something, that's significant. We really want to look deeper into that and see if they've got some swelling anywhere. Okay. Are their jugular veins distended? That's going to signal to you that the blood is backing up through the heart into the rest of the body, and it's all building up into those jugular veins. What do their lungs sound like? They have crackles or wheezes or gurgles? Are they dyspneic? That's going to tell us that their lungs have blood that's backed up into them, and it's accumulating, and it's causing them to have pulmonary congestion because of poor heart function. Okay, it's very important to do your assessment fully. We look at their sputum. Do they have a cough, productive or non-productive? And that's going to tell us sometimes if, again, the lungs are getting filled with blood and are having a bad reaction to that. Okay, what is their mental status? Our oxygen levels in our body are so important, and if we have low levels of oxygen anywhere in our brains, then that's going to cause disorientation and confusion just from the lack of oxygen. We need to check labs, okay, whenever we're looking at any kind of cardiac issues. We draw labs immediately whenever we suspect some kind of cardiac issue. The ones that we want to get are the cardiac enzymes, okay? We're going to look more deeply at these whenever we get into talking about myocardial infarctions. But the cardiac enzymes, they're called CK, CKMB, troponin, and myoglobin. You want to obtain these values very, very quickly as soon as you suspect any kind of cardiac damage. All right, because the sooner we get these values, the sooner we're able to treat them, and it's all very emergent and needs to be taken care of quickly. So basically, the second these patients hit the door, we need to draw these labs. Oops. All right, so the CK. This is telling us if the heart has been strained at all. It's pretty broad. It usually elevates about an hour or two after the MI has been initiated within the heart, okay, the myocardial infarction, which means there's been a lack of blood supply to an area of the heart muscle. So usually within an hour or two after that happens, the CK is elevated. It returns to normal in about 2 to 3 days, and so this is not our indicator of our initial indicator of an MI because it takes so long to see what's happening that we might miss out on treatment of the patient. When it is helpful to see the CK levels is after an MI has already occurred, okay, because then we're looking at ways to follow up and treat following an MI, okay, but during one, this isn't it. The CKMB is telling us that the myocardium has been strained in some way. It's not necessarily heart attack specific, but it usually elevates about 3 to 4 hours after an MI, and it can return to normal in about 72 hours. Now, troponin, this is our gold standard, okay? Our hallmark test that we have to look at whenever we suspect that a patient is in an MI. It is elevated immediately. The second that patient has any kind of infarct in the heart muscle, troponin shoots up. Okay, so this is the one we have got to look at. It remains elevated for weeks afterwards too. So if we're looking at the troponin, we should know if our patient has had an MI or not. The myoglobin is just one that's telling us if the heart muscle has been damaged at all. You see this sometimes in marathon runners because they've run those 26.2 miles and their heart is just working overtime to keep pumping and pumping and pumping and allow them to finish that race. Okay, so it's not something that's causing permanent damage, but it does hurt the heart muscle enough that their myoglobin enzyme is elevated and shows up on this cardiac enzyme test. Okay, so that one is not necessarily specific for a lot of cardiac disease, but it's just a handy fact to know. All right, so just remember that troponin, that's key. Okay, so the tests that we can do to see if our patient is in cardiac distress or has some kind of cardiac issue of any kind, usually we're going to get an MRI of some kind. It's going to show the structure and function of the heart. It's going to show our blood flow through the heart, the perfusion, and all of this is done using magnetic waves. It lets us know just how the heart is working, if it's at high functioning or not. An echocardiogram, also called just an echo, uses ultrasound waves just to see the anterior and posterior view of the heart, and it'll show us if we have any kind of structural changes or any other kind of damage within the heart as well. An ECG or EKG, it all stands for electrocardiogram, shows the electrical rhythm of the heart. As we get into really studying the electrical rhythm, you'll see how that ECG can really tell you so many things. We'll look at that really towards the end of our cardiac series, but just be looking out for that because it's interesting. A Holter monitor is basically an electrocardiogram, but you can take it anywhere. So if we really want to monitor what a patient's heart is doing throughout the day, just a normal day of their life, we'll put them on a Holter monitor. They wear it in a little sack on their hip, and then we hook them up to the electrodes, and then they download every night the rhythms from the day. A stress test, usually you can do an exercise-induced stress test where they hook you up to the electrodes and then you walk on a treadmill and they increase the speed on the treadmill to see how your heart responds. Or they give you these chemicals that basically simulate that you're exercising, and then we see how your heart responds, again through the electrodes. Alright, so we'll talk about the problems next in the next video. Go ahead and review this as many times as you need to, because you need to be really solid on this stuff before you get into the infections. Because once we get into those are the things that we're really going to be treating a patient for, but it's all based on this foundational knowledge. Alright, so I'll see you next time. Good luck studying and getting to know your cardiac system again.